When we consider hormonal replacement therapy in the menopause, we can do that for two reasons. The first reason is due to the symptoms. So it's been shown that hot flushes can decrease significantly, up to 90%, with adequate estrogen replacement. Also, that over and above the symptom relief, we consider that we want to decrease the asymptomatic adverse outcomes associated with menopause, so bone loss. So during the menopause, we lose bone at an accelerated speed, so around 2.5% per year. That leads to osteoporosis, and then the cardiovascular risk. So a long time ago, the study called the Women's Health Initiative was done, and this study showed that in a certain percentage of much older women that we would initiate these days with much other health conditions, that you can have an increased risk, very small increased risk in breast cancer and in cardiovascular risk, specifically small strokes and blood clots. But it's so important to just scrutinize the detail, because this study was done during a time period where we still used very, let's just say, very old school progesterone. And it was specifically in the arm of women that were using progesterone with the estrogen that these consequences or these risks were observed. Nowadays, we tend to use 17-beta estradiol, not necessarily the estrogen that was used in this Women's Health Initiative, and we use much newer micronized progesterones that is much more similar to your own progesterone in your body. So therefore, a significant reduction in risk with the medication we have these days, and also with the route of administration. So by administering these drugs transcutaneously, for instance, we significantly decrease some of these risks because the systemic concentrations is not that high. So the hormonal replacement therapy to include progesterone if the woman has a uterus intact to prevent endometrial CA. When we think about cancers during the perimenopausal area, to always consider breast cancer, irrespective of whether the woman is on hormone replacement therapy or not, because this is the age where you certainly see an increase. Also consider endometrial cancer, colon cancer, and it seems the second most common cancer during this time period is actually lung cancer, which also speaks to the population, suggesting that these people have an increased risk of smoking, for instance, and therefore they've got more lung cancer, and that also predisposes them to some of these adverse effects. So to have a risk-benefit assessment, but in general, in a healthy person that goes into menopause, we would want treatment for at least 10 years. And it's been shown that the benefit of these 10 years of adequate and early treatment can have a significant reduction in cardiovascular risk and mortality risk specifically. And the mortality risk benefit can outlast the use. So up to 18 years after the discontinuation of the hormonal replacement therapy that we tend to give for around 10 years, there will still be benefit if you intervene early and adequately.